Of you.
Good evening, Dr. Binoy.
Binoy, how are you?
Yes, sir. Good evening.
How is your
Good,
family?
sir. How are you, sir?
How is your family?
We are all down COVID.
You are post-COVID or you just recovered?
Family, they are recovering. I mean, I am tested negative.
Okay. That is good. But you are still in the working or on leave?
No, kind of quarantine.
Are you working or
Tomorrow,
on
hopefully, I
leave?
will go for work.
Okay.
No, sir, I am not going to the hospital. Last 1 week, I have been away. So tomorrow, plan.
Dr. Soren, you are there, and the other two discussants, they are also there, I hope.
Yes, sir. Yes, sir.
Dr. Manmohan, are you there?
Yeah.
Okay, Dr. Anabra?
Yes, sir. Yes,
okay,
sir.
fine. Okay, all of you are there. So can we start then? Shanai sir, can we start?
Yes, please. Please.
Jayanti ma'am, may join us during the class? Okay.
Okay, let us start. So let us welcome the student who is going to present.
Okay, so welcome. I will welcome all of you, and then we can start, sir. So welcome to today's ISG Kerala PG clinics, and we are having a teaching clinics today on a case of severe bleeding PR. So it will be a conventional teaching clinics, and the class will be taken by Professor K.T. Shanai, who has been introduced to you earlier, but as many of you may be presenting the case and listening for the first time. He was a former professor and head of Department of Gastroenterology of Government Medical College, Thiruvananthapuram. At the moment, he is a professor and head of Department of Gastroenterology of Sri Kogulam Medical College and Research Center, Thiruvananthapuram. Yes, he is very much interested in research methodology and epidemiology. And you must remember that his paper was quoted in the last class by Narendra sir about the epidemiology of fatty liver disease. This is one of the biggest study in India and especially from South India. Okay. And Shanai sir has a lot of research interest and a lot of publications to his credit. And the internal faculty today is Dr. Binoy Sebastian, the Senior Consultant Gastroenterologist of Medical Trust Hospital. At the outset, I would like to thank you, Dr. Binoy, for providing us the case for today's discussion. And the internal faculty and the moderators for today's session are Professor Jayanti and myself. And the present discussant is Dr. Soren from Medical Trust Hospital. The format is that he will be presenting the case and summarize the case and tell us the summary, and after that the discussion will be by Dr. Manmohan and the management will be by Dr. Anabra. Okay, over to Shanai sir. Jayanti ma'am has joined. Good evening, Jayanti ma'am, and welcome.
I think it is always a pleasure to be associated with students in gastroenterology and teaching them like a bedside and a presentation which will be done by Swaran. And I am also very pleased that I have one of my best students trained in Trivandrum, Dr. Binoy Sebastian. And what I will be doing is I will give a lot of opportunities to Dr. Binoy because as young brain, I want them to be taking the mantle forward. And I will keep myself in a little lower profile and then allow Binoy to ask questions and interact with the PGs. Nevertheless, I will keep everyone in the picture. Thank you, and let us have the presentation. Soren.
Please start your presentation.
Good evening to all. I'll be presenting today's case. I'm presenting a case of a 22-year-old gentleman. He presented to our hospital during the second week of August. He is an engineering graduate. He is from Cochin. the informant himself and the father, and the history is reliable. So his chief complaints were he presented to ER with complaints of bleeding per rectum since 3 days. So his history, he was apparently all right about 3 days back when he developed bleeding per rectum. He initially noticed it in the night when he found blood in stools, followed by which he noticed passage of dark red blood with clots the next day. He gives history of around 3 episodes that day itself with an urge to defecate, after which he presented the next day morning to ER with few more episodes of bleeding per rectum, along with giddiness on standing and generalized tiredness. He gives no history of abdominal pain, no history of perianal pain, no history of mass per rectum. There is no history of mucus in stools or tenesmus. He gives no history of preceding constipation or any history of digital evacuation. He also gives no history of black tarry stools or any hematemesis. There was no history of gum bleeding, nasal bleed, easy bruisability, rash, joint swelling, or fever. He also gives no history of breathlessness or palpitations. When we inquired regarding previous episodes or of a similar presentation, he did give history of bleeding PR that lasted for 1 day in 2018, for which he was admitted in the hospital for a total duration of 4 days. The father this time said that he was initially admitted in ICU, but did not receive any blood transfusions, and he was evaluated with upper GI endoscopy, a colonoscopy, as well as a CT scan. And it was told that there was no obvious source which was found, but he was explained regarding the need for follow-up as well as further evaluation if symptoms recur.
Shanai sir, if you allow, can we interrupt at this stage? You are not audible, sir.
No, I think one of the important things we have to do is discuss why this gentleman had such a profound bleeding at a young age. I think this is one of the important issues in this patient. And can you tell us, based on this history, what is the gravity of bleed in terms of how big is the bleed? And if so, what are the presentations of this case from 2018 to 2021? Dr. Swaran, please.
Yes, sir. With the current episode of bleed, he had bleeding per rectum, which was dark red blood, and it was associated with clots. And on the 3rd day, he also had postural symptoms and orthostatic symptoms. So, which means it's a significant or a major bleed, and around 15% of blood volume loss is there.
Approximately how many percentage?
15%, sir.
15% of the blood loss. Now, I think one of the important things when you start seeing such patients is the age in which they present to you.
Yes, sir.
So that is something very, very important. The age and any precedent or any preceding illness, either a febrile illness or a afebrile illness. Suppose this person had a febrile illness approximately 2 weeks earlier, and he comes with this type of bleeding, the diagnosis will be entirely different compared to a 24-year-old male coming without any fever and presenting with rectal bleeding. Can you tell us the difference between a febrile illness with the bleed and a afebrile illness with the bleed, a similar presentation? Swaran.
A febrile illness with a bleed may be, say, a part of a colitis, sir, or an infectious colitis, or IBD, ulcerative colitis.
The problem is we don't see any of these patients now in a tropical country. But if you look back, typhoid fever, they had a febrile illness, they start recovery, and suddenly the patient has hematochezia and he collapses. The age will be similar, approximately 25, 30 years. But this patient has no febrile illness, but he had a massive bleed or massive hematochezia. So one of the very important symptoms which you should elicit is it for the first time he is bleeding, or is it a recurrent episode? And then you say that he had bled first in 2018
Yes,
and
sir.
now 2021.
Yes, sir.
And usually this type of bleeds are missed not once. They would be missed more than 2 times or 3 times. Finally, you have a great degree of suspicion and you will arrive at a diagnosis. Dr. Binoy, can you take over and ask a few questions?
Yes, sir. So, Professor Shena sir was actually emphasizing on the importance of age. So, how do you approach a patient who comes with this particular history, and how you look into the etiology depending upon the age? For example, children, adolescent, and young adulthood, and elderly or persons
Binoy,
above the age 50.
let us start.
Look into the causes. What are the common causes?
Let us start less than 1 year. Let us start from 1 to 5,
Yeah.
then 5 to 15, and then
Yeah, 1 year, 1 to 5
those age groups.
Childhood. Yeah, could you narrate the different common and important causes of this kind of presentation? Somebody comes with the blood in the stools. Soren?
Yes, sir. In young children or infants, it could a common cause of a blood in stools could be a cow's milk protein allergy.
I think this question was something which you never expected, I believe. Am I correct?
Yes, sir.
See, you must think that children will come. We don't see such problems now. When I was in gastroenterology in 1980, we used to get a condition called necrotizing enterocolitis. Each ward will have 3 or 4 patients. And Calicut, there was a great worker who did extremely best, good quality research in necrotizing enterocolitis by name Professor Verma. And then he moved on to Trivandrum Medical College. Enterocolitis in children, young infants. Interception in young children. These are something which you should know, because though you are an adult gastroenterologist, many a time you will be seeing pediatrics. I see a lot of pediatric gastroenterology. So unless you think about such conditions, you will never make a positive diagnosis. So let us start recapping. A child less than 12 months. Swaran, think about 3 conditions. Or anyone who wants to discuss among the 2 other discussants. They can contribute. Please.
So then, interception, sir, in the
Interception, very good.
diverticulum, sir, diverticulum.
That can also come. Next one.
Then
Infancy,
anal,
1 year or less.
fissure,
So very early onset
Heart-
IBD.
Early onset IBD, I think there are 2 types of early onset IBD. They are all related to some abnormalities in their immune system. But there is one IBD called as very early onset IBD. I think Dr. Jayanti can give us some comments on this. Dr. Marathi was making one presentation about 3 years ago when it was a pre-COVID era. So there are 2 important types of IBDs which come very early in their life. So one of them can come with stunting of growth or with rectal bleeding. So that could be one possibility. The second one is it could be a polyps, a juvenile polyp. A juvenile polyp is something which comes out quite early in their life. And the polyps may be coming out of the rectum. You can see something like a red, small gooseberry like nodule in the outside the rectum. So that could be one of the presentations in a very, very young child. So necrotizing enterocolitis, any bleeding disorders, interception, maybe a variety of inflammatory bowel disease, a polyps, especially a juvenile polyp, they all can come at this age. Dr. Jayanti, we would expect your comments at this stage.
Agree, sir. I really do not know much about that infantile this thing, but I think cow's milk allergy, that's one. Interception.
Okay.
Juvenile polyps may come a little later, I think, by the age of 5, a little later. And prolapsing hemorrhoids, all these with finger digitation, constipation, and all will come a little later, not at infancy. I think most of the differences we discussed at infancy.
Okay. So anything from 1 to 5 years of age, a child is brought to you with rectal bleeding. All these things will again come, but necrotizing enterocolitis will be much lesser. We don't see it very commonly now.
Yeah.
I think I have not seen, or I don't know whether any pediatric gastroenterologist will be seeing the so-called something like what we used to call the necrotizing enterocolitis of 1980s, something like the Papua New Guinea with Clostridium and other microbial etiology, but I don't see them now. Dr.
Not seen at all nowadays.
Varghese, your views, you know.
Yeah. It was in Calicut. We had a lot of cases during my MBBS and all. We have seen cases when we are posted under Professor Warma. But after that, I think this condition is waning, and we practically do not see this at all. I would say it just disappeared.
Like a tropical sprue.
Yeah, tropical sprue. There are some illnesses which are disappearing. Yeah.
Dr. Binoy?
Yes, sir. I mean, regarding necrotizing enterocolitis, well, we are also not seeing that many cases. The last case which I saw was around 3 years back, admitted in pediatrics, one young girl with abdominal pain, but the presentation was totally different. It was like a sepsis, and CT showed thickening and air in the bowel wall. And that child
So it has not disappeared completely. So that is still there. Okay. Severe necrosis of the intestine, hemorrhagic necrosis with air in the wall, air in the portal vein, septicemia, it's a very dangerous condition.
And regarding the cause bleeding PR in an infant, most likely, most of the time we encountered with either cow's milk allergy. This started either with at the time of weaning off from the breast milk, cow's milk allergy or food allergy. So the most common situation which we encountered, we had done scopies for 2-3 infants, and they all had mild diffuse colitis, patchy colitis. The biopsy obviously said only colitis, but once we stopped the particular weaning food or the cow's milk, the bleeding stopped. And in the 1 year to 5 years age, I think all these etiologies still apply, but the polyps probably would be the most common cause at this age, because they're present with typical painless rectal bleed.
Yeah, what we don't see today is the Shigella. So in the 1980s to 1990s, we used to get a lot of Shigella Shige, especially in coastal belt. And they used to come with rectal bleeding and pyrexia and deteriorate very rapidly. So I think we don't see such illnesses like Shigella dysentery or Shigella Shige. So that is, so as Binoy mentioned, polyps should be coming as one of the important between the age of 1 to 5 years. Interception will again come as one of the DD at this age, between 1 to 5 years. I don't think Escherichiasis or
the fissures and hemorrhoids.
Strongyloids, sometimes massive strongyloids can come with rectal bleeding, or enterobiasis can come again with features of Dr. Jayanti?
Redworm infestation, sir.
Yeah, pinworm infestation. I think Professor Balakrishnan was studying in fact, whipworm colitis.
Well, sir,
he presented one of the best papers in a World Congress of Gastroenterology in Stockholm. So there is a condition called whipworm colitis. We don't see it now, but they all can come in children.
Yes, Vipon colitis was there earlier, especially from socially and economically backward persons and nutritionally deprived children. They come with blood and mucus. Instead of profuse bleeding, it is mainly blood and mucus like a dysentery, and it is like a chronic diarrhea with profound malnutrition, pedal edema, hypoalbuminemia, all those things. And on colonoscopy, we will find the mucosa studded with these bookworms. It is like it is described as coconut cake appearance. And we can actually pick up the worms which are studded in the mucosa and then take it out and examine it under the microscope. We used to crush it at a glass slide and to look at the ova, because we don't know how to identify the worm because we are not a zoologist or entomologist, but we look at the worm, so ova under the microscope, and we used to diagnose. And in fact, Dr. Sunil Mathai, when he was a PG student under me, we have actually presented a paper in ISG because we found oral mebendazole was not very effective, and we give enema of mebendazole and found it was very effective in that condition. So that is a historical thing about it. Bookworm colitis.
Whipworm colitis.
I
Whipworm.
also remember seeing one case along with Dr. Sunil Mathai. One child undernourished has come from a faraway place, studded with bookworms. And we had that video with us, and it was presented in one of the national conferences for the video conference. So that was many years back. So again, we gave enema, and the child remarkably improved. And 3 weeks later, we did a repeat procedure, and we found that the worms were still there, but compared to what it was initially, it would have been reduced by more than 70%.
I think the
So such things are very rare
pediatric
now.
pediatric gastroenterologists now recommend enema rather than, okay, they give tablets, but enema is also given in addition for this condition.
Dr. Binoy, do you want to further discuss based on this history for that?
I think we'll move forward, sir.
Sir,
Okay.
I want to ask something about that constipation or digital evacuation. Dr. Soren, why did you mention digital evacuation here?
Here was thinking of a possible perineal trauma, local trauma, which could lead to some ischemia or something like a solitary rectal ulcer syndrome, sir.
But solitary rectal ulcer syndrome seldom produces such massive bleeding.
Yes, sir.
It
Yes,
may
sir.
produce copious mucus diarrhea, constipation, and traces of blood, but such massive bleeding is unusual. One thing which I wanted you to improve in your history is that when somebody has such profuse bleeding, either it is with a mucosal inflammation or without a mucosal inflammation. So we would have been much happier if there were a little more history about whether there was an alteration of bowel habits towards diarrhea, an increase in bowel frequency, whether there was some diarrhea, and whether it was initially mixed with stools. And of course, you said it all started all of a sudden, and therefore all these things are relevant. But I think the digital evacuation part perhaps could have been avoided because that may take you to a different direction. Okay.
Yes,
Rest
sir.
of the things like gum bleeding, nasal bleed, easy bruisability, all those things seems to be okay. Why did you mention breathlessness and palpitation?
If since it was a bleed which is causing orthostatic symptoms, if at all to see the degree of the anemia, sir, because of the anemia.
Okay, but usually these
Can
symptoms
I
are
ask one question?
in
Can I ask one question?
chronic anemia. But anyway, there was a gap of 3-4 days, so
Yes, sir.
there can be symptoms of anemia. But usually, effort intolerance, breathlessness, palpitation, and even sometimes angina due to anemia can occur. Okay.
Yes, sir.
Okay. Can we move forward, Dr. Binoy?
No, he didn't tell us about the causes of bleeding in this particular
Okay. Okay. Let us find out his DD at this time.
Sir, in this age group, sir.
Yes, yes. Now, this patient, you can tell us what are the differential diagnoses.
Shall we complete the entire history for the formality's sake?
Anyway,
ma'am?
okay.
I think
Jayanti?
that history of 2000, can you hear me?
Yeah,
Yes.
yes.
The history of 2018 is very, very important. That will give you a clue to the diagnosis of the present complaints. I think there was no expansion on that history. You just mentioned that there's history of 1 day bleeding in 2018. I think I would spend another 5 minutes or so just trying to find out what this bleed was, which is overt bleeding. But to what extent, they said, when was the procedure done? Few days after the admission, patient was admitted for 3 days. It will give you a complete clue as to what is the this history will give you a clue to your present diagnosis. That's my take. That's my take on this case. And there's
Yeah.
Dr. Soren, you said that you was in ICU. That means what was the quantity of bleed? Any idea? Was it a very severe bleed? Did he have giddiness, postural giddiness, etc. that time also? And again, that time whether there was a febrile illness, NSAID intake, whether there was a abdominal pain, whether there were altered bowel habits, all those things need to be present.
Yeah, because CT itself has been done. So it is, you think it's an obscure overt bleed, that one? What is your comment on that? Do you think it's an overt bleed, but an obscure bleed? What's your comment on that?
Probably an obscure overt bleed, ma'am.
What was the age of the patient? I forget the age.
At 2018, he was 19 years, ma'am.
19 years old. So in
Yes,
19 years old, patient has a massive bleed. You did not mention that it's massive. You just said, it looked to me when you said history of bleed, I thought of what just fissure in or something. And suddenly you said he was admitted in ICU. So you have to expand. This particular history will give you a clue to your present diagnosis. And this is exactly, in fact, what I would say is I would present the chief complaints as 2 episodes of bleeding per rectum in 2018 at the age of 19 and 2021 at the age of this. And then say we can start, the present history is this. However, in 2018, the type of bleed, the extent of bleed were all similar to this, extensively evaluated. Then we know what is the degree of bleed. A passing statement of just giving history of bleeding per rectum for 1 day is meaningless. Okay, you have to expand on this particular history. Otherwise, the discussion will go haywire. You will not know where you're going.
Soren, do you have any more information on the CT scan or what was the hemoglobin level at that time?
Sir, he did not require any transfusions that they were very sure of, and they only had just a one-page summary. There was no other lab investigations available with them.
But they kept the patient for 4 days and then discharged him and asked him to come back if there is a recurrence. But did they have any working diagnosis at that time?
You think it was a varicose bleed? And it was missed also dilophoid ulcer bleeding. What is your comment on that? You have to give a comment on this. This particular bleed is most important history in this particular case.
But probably you don't have any information on that episode other than what you have presented here.
Okay, now I think let him complete and we will ask the DD.
Okay.
This information that it is an overt, obscure, severe bleed.
Was it
Okay, Soren, proceed.
Was it a severe bleed, sir?
Ma'am, back then they were very specific to say that there was only, the history was only for 1 day, madam. And after following 1 day, the bleed had stopped.
But just listen 1 minute. You will not ask for the CT abdomen, okay, for the local bleed, okay, number 1. Number 2, okay, we do an endoscopy, but when you say just, for you, it was just 1 day bleed. Just understand, I would spend definitely some more time, just 1 day bleed, and he has an upper GI endoscopy, a colonoscopy. Would you do that in your day-to-day practice? Patient comes to you with bleeding per rectum and says, I passed blood yesterday, 10-15 ml or so. You do an upper GI endoscopy, you do a colonoscopy, you do a CT scan. Just be careful. I tell you, the examination, the focus will be only on this history. This will be your captivating presentation that will capture the attention of the examiner to discuss this particular thing. Okay, just carry on now.
So,
Okay. Past history.
yes, no other comorbid illnesses, no history of any previous surgeries.
What all comorbid illnesses you are interested in this particular case of recurrent bleed? No, for an undergraduate, they usually know history, tuberculosis, hypertension, diabetes, etc., is okay. But at your level, when you ask for a comorbid illness, it must be highly specific to this particular problem. like a bleeding PR. So which all comorbid illnesses which were in your mind when you told this history?
Any history of any cardiac dysfunction or any cardiac history, sir? If there is any history of any previous cardiac surgeries or any prosthetic heart valves.
So
Or,
what is in your mind?
This patient of anemia that he asked for, no? Anemia, transfusions, fatigue, because it may be that he's got an open bleed and it's not manifesting, and suddenly he has one over bleeding. So just be careful. Those are important no histories. That is, he's absolutely normal after the age of 90, no symptoms, absolutely active, and then he has a second bleed. These are the important negative histories that you class.
yes, ma'am.
Suren, what are the comorbid illness you think of some significance in this case? You are thinking of any vasculitis or any other inflammatory diseases or any drug intake for any
Yes, sir.
illness? What are the things?
Vasculitis could be a possibility, sir.
Okay.
Like
And then-
Behçet's or Henoch-Schönlein purpura.
Okay, next one.
Or
You said about Behçet's. Okay, good. Intestinal ulceration and it can produce massive bleed. Okay.
yes, sir.
Okay.
Or if he has any kind of bleeding diathesis, hemophilia, or an ITP, or any von Willebrand disease.
Okay.
they
Bleeding
could- they
diathesis
could-
from childhood. Okay,
Yes, sir.
agreed.
Yes, sir.
It need not be coagulation disorders alone. It can be hereditary hemorrhagic telangiectasia and conditions like that as well. Okay.
So when you write no other comorbid illnesses, it is better that you write that there are no other hematological illnesses which could contribute, or any vasculitis, either any other collagen or other types of vasculitis. That will be much better rather
Okay,
than
sir.
making a statement of a comorbid illnesses.
Yes, sir.
What surgeries do you think will have been of some consequence here?
Since it was a massive bleed, sir. So if at all there was any history of any abdominal aortic aneurysm.
Okay, so what type of surgeries will contribute to this? I think when you write, I think this is a general statement which people give. I think the second part is not very essential at the age of 24 and at the age of 19 years presented to you. I think it would be better if you can give very specific illnesses which you think maybe like anticoagulant intake, aspirin intake, or something which could contribute to bleed. I think, and any illness which you can think about, which occurs before the age of 19 years. I think that will be better presentation rather than 2 lines like no comorbid or no previous surgeries. I think better you can be more explicit.
Yes, sir.
Okay, Binoy?
I think, as you said, sir, the history has to be a little more elaborate and has to include more negative history, valid negative history. These are only 2 statements. I agree with you, sir.
Dr. Varghese Thomas, do you want any more at this time, or we will go for the DD?
Okay, so I think Dr. Soran, you have to think of this particular case as a case of recurrent GA bleed and think of the conditions which can predispose to recurrent GA bleed, systemic illnesses. Okay, apart from pure GI tract diseases, systemic illnesses, and in fact medication. Shana said NSAIDs and other analgesics he may be taking for some other arthropathy or some other illness and things like that, or anticoagulants, etc. So such things should come to your mind and it should be relevant. It should not be far-fetched. That is also important. The negative should not be too far-fetched also. It should be extremely relevant to the case. I think he can move forward.
Yes.
Uh,
Okay.
There was no history of bleeding diathesis in family members. There was no history of any colorectal malignancies or colonic polyps in family members. He's not on any regular medications, and there is no history of consumption of any over-the-counter medications.
Okay. Anything personal?
His diet was mixed prior to the illness. His appetite was normal, adequate sleep. He has no habituations.
Okay. So now you have completed the history. Am I correct?
Yes, sir.
So based on this history in a young male, I think you should be able to give us at least 3 important possibilities in the priority of first, second, and third.
Sir, can I interrupt, sir?
Yes.
Can he summarize, because they have to learn the art of summarizing, because from that itself gives them extra advantage if they are able to summarize the case properly and then list out the differential diagnosis. So shall
Okay,
we
good,
ask him
good.
to summarize
Yeah.
the relevant things?
Okay.
So, is a
22
23-year-old gentleman.
Yes.
Sorry, sir.
Continue,
23-year-old gentleman. Is 22-year-old gentleman with a history of probable obscure GI bleed 3 years ago, currently with a painless lower GI bleed since the last 3 days, associated with orthostatic symptoms.
Okay. You write orthostatic symptoms or giddiness.
Giddiness, yes, sir. On standing, giddiness on standing.
Giddiness on standing.
Here
Okay, now you are,
few relevant negatives also should come. Understand? Few relevant negatives also should be added. Here only added positive things. Some very relevant negative things also should be added to make it complete.
Yes, sir.
Okay. Okay, over to Shanai, sir.
okay. Now I think you can also add like no history of any hematological illnesses in the past or intake of anticoagulants or NSAIDs, aspirin. All these things you can mention. So, but it has to be brief and it should contain the age of the patient. And since the occupation is also very important, and then the presenting features. So with this, I think, what are the possibilities?
On what basis do you say it is lower GI bleeding? What makes you feel it's a lower GI bleed?
Ma'am, he gives a
Latest
history of
GI bleed. How do you classify GI bleed in the present days?
upper GI bleed is bleeding proximal to the ligament of Treitz, ma'am. Lower GI bleed is
Sir, and ma'am is asking you, what is the clinical clue to say that this is lower GI bleed? Because upper GI bleed with the severe hematochezia also can present like this.
And what is the current definition of GI bleed? How do you define anatomically? You have a proximal, that's upper GI bleed, proximal to ligament of Treitz. Nowadays, we have a mid-gut bleed, not true mid-gut, but it's a small intestinal bleed up to eosinophil region, and then you have the lower GI bleed. So lower GI bleed is actually just the colon. Because with the advances in endoscopic procedures, with enteroscopy and capsule and all that, the mid-gut bleed goes as a separate classification. So small gut bleed goes as a distinct bleed as one of the causes, as one of the classification. So in your patient, how did you say it is a lower GI bleed? The question will be here, what is lower GI bleed?
I think it would be better if he mentions the painless hematochezia.
That's all. And then, so you have a wide differential. You can discuss all the differentials you want, right? From upper GI to mid-gut and the lower GI.
Yes.
You
I think
there was a question whether we should put obscure also.
And 1 minute, the other one is you have to mention the severity. When you just say has 2 episodes of lower GI bleeding means nothing. Expand on that severity. What was the severity of the bleed? You have to mention in the summary, requiring transfusion, not requiring transfusion. Is it just this thing? Is it a massive bleed? You have to mention that. And in absence of abdominal pain, those are the things. Now, absence of any other respirating factors like, you mentioned those causes. Can acid peptic disease present like this? Duodenal ulcer, painless bleed?
if it's a massive upper GI bleed, yes, ma'am, it can present.
Exactly. So don't mention lower GI bleed. Mention the severity of the bleed. So you have a wide differential. right from hematuria, pancreaticus, hemosuccus pancreaticus, then you have the gist, you have the Dulophoid's lesion that can occur in the upper, it can occur in the middle, it can occur in the distal tract. You have a wide differential. Why is it important? Because they could not pick up this lesion during the first evaluation, which means it is an arterial bleed which has stopped. That's it. And they've done only CT abdomen. They did not do a CT angio because the bleed would have stopped by then. So now you have a wide differential, something like an arterial bleed that is presenting like this. Have you understood? So therefore,
Yes,
don't comment on lower GI bleed. Do not. You have to mention about the severity, and you have to mention in your summary a bleed that occurred in 2018. It is not obscure. Obscure means you do 2 times upper GI, 2 times colon, and then say it is obscure and overt. Otherwise, you do not. They're done only once. And it's not completely evaluated. So it is overt bleeding. We do not know whether it's obscure. It's not been extensively evaluated in the first go. Are you listening about what I'm saying? Understanding what I'm trying to comment?
Yes, ma'am.
He's not been completely evaluated in 2018. They've done 1 upper GI, 1 colon, and a CT abdomen. That's all. Had they pursued during the bleed, what I would have said in the discharge summary, when he has a bleed, come immediately within a few hours of bleed so that they can pick up the bleed. Apparently, it's an arterial spurt or something because general examination overall, which is somewhere in the mid gut because upper is normal, lower. So now your focus is towards middle. But angio is not done. So you cannot call it as obscure. I stand to correction. BT, you can just comment on that.
Yeah, because it was he was not even though upper angio, endoscopy, colonoscopy, CT was done, it does not complete all the investigation. So until the investigations are done completely, we can't say it is obscure because midgut was not evaluated properly. Mucosal lesions cannot be found out by an ordinary CT at all. So until and unless it is thoroughly investigated, we cannot call it obscure. So I would have preferred maybe recurrent or 2 episodes of GI bleed with the current one in the last 3 days and with significant orthostatic symptoms. And of course, with no abdominal pain, no alteration of bowel habits, no NSAID intake, like that, some relevant negative history.
Well, I think, can we ask them to get some DD at this time? Swaran, some differential diagnosis?
He has to give a DD at this time. Yeah.
With this history, would like to localize it either. It could be a small bowel bleed, a proximal colonic bleed, or a massive upper GI bleed.
Which order? Which order are you doing?
What is your bet? What is your bet? Is upper, midgut, or distal? What is unlikely in this patient?
Unlikely is distal, ma'am.
Distal means what? Can it be a diverticulum from the right side? How does a diverticulum present? Right-sided colonic diverticulosis. They all are bleeders. They're wide mouth and bleeders. Only thing, age is not there. That's all.
I think only thing which you can mention is that it's very unlikely to be an upper GI bleed. If somebody has done an endoscopy very meticulously, and then there is no history of any hematemesis unless the blood has been so rapid it has gone down, I think I would be thinking more in terms of a midgut or the hindgut. The upper part, like up to the ligament of trees, I will think very unlikely, less than 10%. Whereas 70 to 90%, I will think in terms of a distal small bowel or in the colon. Dr. Jayanti.
Yes, sir. Because endoscopy is being done, at least, but still, Dulophoid's lesion can still be missed. That can still be a possibility.
Yeah, that is still a possibility.
Distributors more present with massive bleed. They're more of silent bleeders present with anemia. So that is unlikely. Tumors are unlikely from the upper GI, but Dulophoid's lesion will come as an important duty from the upper GI. It is painless bleeding, which acts like a spurter, and they bleed. That's one thing from the upper GI. Midgut more likely because at least there's one colonoscopy telling us that there's no diverticulosis. So colon becomes unlikely or less likely. So therefore, shortlisting, I would still consider upper GI bleed in that Dulophoid will come as one of the DDs, and the midgut and have a wide differentials that you can discuss. What are your differentials for a midgut bleed? Midgut means small intestinal bleed, not a true midgut.
Dr. Saran. Okay. please tell us the differential diagnosis. Ma'am has told no. So now please tell us the possible diagnosis of midgut origin or small intestinal origin.
Small
Small
intestinal.
intestinal origin, I think probably yeah, I have seen jejunal diverticuli bleeding massively. Jejunal diverticuli, large jejunal diverticuli bleeding, I have seen. Lymphomas in the small bowel, sometimes they can come with a massive bleed. And the third possibility is anything like, as we mentioned, lower down like a Meckel's diverticulum. This is something which we miss again and again till you think about it and never make a diagnosis. Diverticular disease probably unlikely because at the colon, because the previous colonoscopy, they would have picked up at least a few diverticuli which were there. And at that time, they could have found out if there was a bleeding. So I think jejunal diverticuli is one possibility. Meckel's is another possibility. A small bowel lymphoma.
But spaced by 4 years, 3 years.
Yeah, sometimes this is an indolent one. It can be slowly progressive. Sometimes they can get an aneurysmal dilatation of the bowel and suddenly there could be a bleed. I've seen it happening, but may not be at this age of 22. But these are the possibilities. Swaran, do you have any other possibilities in the midgut?
Could also be a midgut dulcifer lesion, sir, or could be the intestinal ulcers.
Yeah, there is a condition called as I used to see this condition very frequently. The distal ileum. Sometimes there can be idiopathic ulcerations in the distal ileum. And I have seen people coming with a massive bleed, even undergoing a laparotomy and undergoing a resection of the bowel. People thought it was related to enteric coated potassium tablets. And this condition was described with many case reports of massive bleed occurring from the distal ileum. Dr. Jayanti, your views on this?
I agree, sir, to most of the differentials you mentioned. I think again, Julophoids again will come high on the list, number one. And we have seen jejunal Julophoids have been reported. Meckel's will also come as an important DDS painless bleed. Angiodysplasias usually present more as melena. The cases that I've seen in CMC well, we had about 8 or 12 cases all presenting with recurrent bleed, but with melena, not with hematochezia. Other thing is,
Angiodysplasia is more in elderly, no?
Heart tumor, just polyps and all, those are all, they will not present as frank bleed. They present as anemia, they present as requiring transfusions, but fresh bleed in this manner is more of an arterial bleed, the way you're describing. So to me, I will still vouch for a Julophoids or a Meckel's diverticulum as my two important differentials.
Dr. Binoy?
Yeah, nothing to add, sir. Basically, a CT was taken 3 years back, which didn't pick up anything in the small intestine. So probably lymphoma, polyps are unlikely. And the fact that the patient doesn't have any abdominal pain, any mucosal symptoms excludes inflammatory bowel disease and inflammatory areas and inflammation which leads to bleeding. There is no drug history. So it boils down to either vascular malformations or diverticulum. I also agree with the differentials.
I think, can we move over to Dr. Manmohan for the next part of the discussion?
Yes, yes, please.
So thank you, Dr. Swaran, for the discussion and presenting the case. Please be around in case we have some doubts about the case. We will have to answer. Okay.
Yes, sir.
Yes, am I audible, sir?
Yes.
Yeah. Physical examination. Patient is conscious, oriented to time, place, and person. Vitals. Patient is tachycardic. Heart rate is 110 beats per minute. With regular rhythm, normal in character, good volume, no radial or radiofemoral delay. Patient BP is 100 by 70 millimeters of mercury in supine position in the right upper limb. Saturation of 95% and respiratory rate of 18 per minute with abdominal thoracic type of breathing. Next slide. On general examination, there is no pallor. Then JVP is normal. no petechiae, purpura, ecchymosis, nevus, macules. Oral cavity is normal. Skin, hair, nails are normal.
This was at what time? This is examination was at admission or after he has recovered?
It was at admission, sir, on presentation.
Yeah, because you say there is no pallor.
Yeah, sir.
And I think 3 episodes of hematochezia, and then he had orthostatic hypotension and giddiness, and you say that there is no pallor.
It was at presentation, sir.
Seems to be some inconsistency.
Yeah, but still you would have expected a pallor because patient had orthostatic hypotension. It suggests probably a massive JB.
And the patient is still has tachycardia. So I think there is some problem in that. Okay.
Next slide. On GI examination, oral cavity is normal. With inspection, umbilicus is central, no scar.
I think you should not say oral cavity is normal. I think what you look in the oral cavity and what you wanted to find. At least you could say there are no telangiectasia,
No telangiectasia.
no purpurae, or there is. I think we have seen nasopharyngeal fibroma. Sometimes we have missed, and then they come with the bleeding. So I think you must mention. Everything normal is not a very clear way of presentation. You should give what you look for and what you did not find.
Can I ask a question, sir?
Yes.
Dr. Manmohan, in a patient with a GI bleed or a massive GI bleed, we have thought of so many differential diagnoses, confined GI tract and systemic disease. So what all things you look in the general examination to get a clue towards our diagnosis?
The thing I would one is in the BP, sir. One postural hypotension I would have checked.
Okay, that gives us a severity. That gives us the severity, not the clue regarding the diagnosis. No severity.
Yeah, sir.
What I am trying to find is that by looking at the skin, by looking at the mucous membrane, Shanaisa specifically said oral cavity examination is important, skin examination is important.
Yes, sir. Any petechiae or purpura for bleeding.
Okay, petechiae, purpurae, ecchymosis.
Ecchymosis, yes, sir.
Okay, then
I have seen for any oral cavity, any nevus. Oral cavity nevus.
There are rare syndromes where you can have pseudoxanthoma, elasticum, and all those things can be found out by skin examination. Okay, elasticity of the skin. Okay, then cutaneous telangiectasias. Okay, right. And in the mouth, specifically telangiectasia of the tongue, lips, buccal mucosa, palate. That's one area where it may be there and we may miss it completely. Okay. So those areas also to be looked at.
Yes, sir. Then other thing is I would have like to consider to see for.
Can I just?
Yes, please.
Hyperpigmentation, oral cavity, particularly with the polyps, Fuchs syndrome, pigmented spots.
Pigmented spots.
Especially in the lips and
buccal mucosa. Yes.
And you can also see the nails.
Yes. And also I would have liked to see for oral ulcers, because one of the difference you would have thought of IBD, recurrent oral ulcers.
So the general examination in a patient with a recurrent GI bleed is very important, and you should tell us, of course, blue rubber blood syndrome is mostly in children where they have GI bleed, not at the age of 22. So there are a lot of syndromes associated with the GI bleed from infancy, childhood, adult, etc. And all these things can be, probably some of these things can be found out by general examination, a meticulous general examination. In fact, if you say certain things which are negative, that means the examiner will get an idea, oh, this chap knows this differential diagnosis, like that. Rather than a bland negative, if you qualify the negative with some of these points, you will get, you can impress the examiners. Okay, over to Shanaisa.
I think Dr. Binoy, anything more which you want in the general physical examination?
No, sir.
because you mentioned about the pure sugar polyposis, I think like pigmentation. And he mentioned also in the previous speaker mentioned about the family history of colorectal malignancies. So you should think about whether there are any other cutaneous stigmata of polyposis syndromes. You may mention it, or you can make a blanket statement that there are no cutaneous manifestations which I have seen in this patient. Okay.
Okay. Then on abdominal examination inspection, umbilical is central, no scars, dilated veins. Then all quadrants moves correspondingly with respiration and hernia orifices were normal. Next slide. In palpation, there is no non-tender and no massive swells for abdomen with no organomegaly. Percussion is tympanic note with liver span is 11 centimeter. Auscultation, no bruit and bowel sounds are heard normally. In parectal examination, there is no blood or no external hemorrhoid or visual. The other system examination within normal limits.
So it all depends upon at what time the PR has been done. If somebody has come with 3 episodes of bleeding, and then you do a PR and your finger is not with any blood, this also is something which is inconsistent. Unless somebody has given an enema and evacuated the blood. I think if somebody has passed the blood and then you do a PR and you don't find any blood in the finger, I think there are something which are missing here.
Here I would have expected a fresh bleeding or at least clot.
I should have seen, I could have found if somebody has passed the blood or clots, I would have found some clots in the palpating finger. Okay, we have to believe what has been given to you.
Yes.
Anything next one? You're finished with physical examination?
Yes.
Okay. So you would like to entertain any differential diagnosis at this time?
Well, more the differentials are more towards the same thing because there's nothing extra to add on. One thing is midgut lesion is one predominantly I would still like to consider in this case. Probably because of the nature of the blade, still I consider it a midgut diaphragm lesion first, and then regional, as we have discussed, regional diverticular bleed, or a Meckel's would have been third, and a small bowel and small bowel tumors would have been fourth. Then in the lower J, I would have liked to consider rectal and diaphragm lesions, and less like the ulcerative colitis. Would be lower down in the order.
Yeah, one lesion which we find, but we don't find it very commonly, is colitis cystica profunda. I think this is one condition which you should think about, because I had seen a couple of cases, and a few weeks ago, I think we saw one such patient, my colleague in Anantapuri, rectal bleeding and found like a growth, and then the palpating finger, it was felt like a growth, and then we had to do like a polypectomy and get the final diagnosis. So they can also come with the profuse bleeding, colitis cystica profunda. This age is the same age, about 20 to 30 years. I'm just putting one more DD for you, but you would have found some blood in the palpating finger. But this will be one other added diagnosis.
Yeah. Yes.
So Varghese Thomas, so would you like to have further discussion at this point, or we will start looking at some of the lab evaluation and then take it forward?
Dr. Manmohan has listed the causes, but I think he has to give us a few differential diagnoses in the order of priority. He has mentioned up to rectal ulcer. So I think at this juncture, you have to narrow down to few possibilities. We have earlier ruled out colonic disease because of the history as well as the colonoscopy findings. We have narrowed down to small intestinal disease, and we have asked Dr. Soren to say the order in which these diseases can be considered. So please tell us the order in which you consider your few differential diagnoses, and then your reason for that.
Yes.
Because this is the way examiners will ask you.
Start off saying it is an overt bleed, overt GI bleed.
Red bleed.
Most likely upper GI bleed. My differentials for upper GI bleed are this. That is, then they'll ask you what's upper GI bleed.
Okay.
Say my differentials for the small gut bleed are these, and my differentials for the distal, that is colonic bleed, are these in order. So short list, my differentials would be 1, 2, and 3. That's the way you must answer, because your evaluation will be guided by your differentials.
Okay.
Everything.
Yes, please. My differential in the upper J bleed, considering all the things, it's more of an arterial bleed. So upper J, I would like to consider dilaphoid lesion as the priority in the upper J. In the mid, the small intestinal bleed, I would like to again consider it probably a dilaphoid lesion. Second would be jejunal diverticular bleed. Then third, I would like to consider Meckel's diverticular bleed. Then other things will be it can be due to small intestinal lower down will be small intestinal tumors like lymphomas or polyps, maybe then. Then other thing is lesser lower down angiodysplasia. In the colonic, if I have to consider, it will be more of a dilaphoid lesion in the colonic dilaphoid, or else ulcerative colitis type of bleed. It will be lower down the order.
They had a colonoscopy in 2018.
2018. Yes.
Unlikely to have an ulcerative colitis with such a massive bleeding. Very unlikely.
Yes.
So that cannot be a.
You cannot give a ulcerative colitis in such a patient. You can never give a medium ulcerative colitis.
Okay.
Even in the absence of a colonoscopy report, what is there to consider ulcerative colitis? Suppose you are not aware of the colonoscopy report, you are seeing the patient for the first time. What are your points in favor of ulcerative colitis in this case?
The stool frequency is not increased.
Stool frequency. Yes.
Stool frequency is probably normal. They have not mentioned. So in the absence of any diarrhea,
Yes.
I think.
Not anything on that.
So massive GI bleeding can occur in ulcerative colitis, but that happens in severe ulcerative colitis, and they have symptoms of severe colitis, severe colitis and proctitis. So increased bowel frequency, loose stools, and prior history of blood and mucus. And even if you consider it an acute ulcerative colitis, which may occur in 10 to 15% of patients, even it will evolve over a couple of days, not just massive bleeding all of a sudden in the night, producing hypotension and postural giddiness. That is not the presentation. So ulcerative colitis, I will not consider at all in this patient from the history, because you must be careful when you list out things. It must be most likely diagnosis as from the history or physical examination. Okay. Over to you, sir.
Dr. Binoy, are you happy with these differential diagnosis in the upper midgut and in the colon?
So one question is regarding the order of the diagnosis which he made in the midgut. Like the first possibility, LFOE.
Yes.
And third is Makers diverticulum. Would you like to consider revising the order? Which is the most common situation?
Not audible.
Dr. Manmohan.
Diverticular.
Okay, you are there.
Yes, sir.
Did you understand the question? Did you understand the question?
Yeah, sir. Yes, sir.
If you don't understand the
Yeah,
question,
sir.
please feel free to ask us. Okay, then no problem. If you don't understand, you are always free
Yeah,
to
sir.
ask what exactly is in our mind, because due to communication gap, you may not be understanding it properly. There may be some technical problem. So if you are not able to hear, please ask us.
Dr. Binoy is asking you the three possibilities
Yeah,
in
sir, I
the
understood.
small vowel. 1, 2, 3 in the
Yeah, sir.
90% possible, 70% possible, or 30% possible.
Yeah, sir. Dial first, I'd like to still consider rupture. Then I'd like to consider Meckel, then regional diverticular.
So
bleed,
3.
sir.
So Delphi, Meckel's and jejunal diverticuli. They are in the order. Say 90,
Yes.
70, and 40 or 50.
Yes, considering the age of the patient and all this.
Dr. Binoy, are
Okay,
you happy
fine.
with this?
It's okay, sir. We'll keep it like that.
Okay. So I think we are at 9:05. So let us now look into what has been the lab evaluations and try to gather more information.
So shall we ask him how he will investigate, and then we will look at the available investigation.
Yes, sir. I like basic investigation in blood test. I'd like to ask CBC, complete blood count, PC for the HP level, hemoglobin, then platelet count I would like to see. Then other thing is I would like to see for the creatinine values, sir, urea creat. Then
I think you have to, Manmohan, you have to spell out. I want to know the level of hemoglobin or hematocrit. Very important, the point of how big was the bleed.
Yes,
you want to know the creatinine because you want to investigate him further and to know whether there is a renal problem.
Acute kidney injury or not.
Yes. And number 3, what else you want to know?
Next will be endoscopic evaluation, sir.
Or do you want to have any ultrasound at this time, or you want to bypass the ultrasound?
No, sir. I would like to do a non-invasive investigation with the ultrasound abdomen.
Okay, so let us look at the hemoglobin.
Yeah. Then HB is anemia is better, 8.5. Then PCV is low, 24.4. Platelets are normal. Creatinine is normal. Then blood urea is 46 normal. Then ESR is normal. ECG was sinus. It was the patient had tachycardia. Sinus tachycardia. Yes.
What about
then
coagulation parameters?
Yes, sir. I want to see for PT, APDT, and INR level. With INR is 1.2. Prothrombin time is normal, 16 seconds. Sir. Bleeding time and clotting time are normal, 1 minute and 4 minutes. And I done liver function test. Sir. Liver function test, total bilirubin is normal, 0.79, and the AST normal. Albumin is slightly lower at 3.1, with globulin 2.2. And there is total protein would be 5.3.
So at this time, what do you think is happening in this gentleman? Hemoglobin is not very low, 8.5, with a low hematocrit and a little lower albumin levels. Otherwise, everything seems to be okay.
Normal. So it's not due to the bleeding diathesis, sir. Then there is anemia, some amount of anemia is there, sir. Then probably total count is probably leukocytosis is related to the blood loss, or it can be reactive leukocytosis.
So the only evidence at this time is that there is evidence of bleeding. There is a blood loss.
Blood loss.
That's all.
Yes, sir. And there is no AKI.
Dr. Binoy,
would you like to add anything at this point?
Now, looking at the profile, the PCV, MCV, does it tell you anything? His hemoglobin is 8.
More of my
MCV is normal.
MC is on the lower end of the normal, sir. It's
Sorry?
normal. Yeah,
Yeah,
MCV is not the lower end of the normal, sir.
that signifies it's an acute bleed. Probably, if it was a
Yes, sir.
chronic bleed or
Yeah, sir.
intermittent
It
bleed, that should
signifies
have been low.
more of a yeah, sir. More of acute bleed. It should be.
And CRP is normal.
Yeah, sir.
That signifies what?
No inflammatory pathology,
Yeah, it might exclude inflammatory bowel disease and
inflammatory bowel disease and that.
You think patient has got chronic anemia?
Ma'am, MCV is on the
What in the blood evaluation will tell you that you could be having chronic anemia? RBW?
red cell differentiation, RBW better.
All these questions have been asked in D&D exam.
Okay.
The evidence of chronicity.
platelets. Usually in chronic anemia, the platelets also might go up.
Yeah, sir. Yeah, platelet is normal.
Blood urea 46. Any take on that?
The blood urea is a little higher on the higher side.
You have to differentiate an upper GI bleed from lower GI bleed. What are the things? What happens to the urea? Urea will be high in mid-cut, okay, upper GI bleed. Whereas in colonic bleed, usually urea is normal. Okay, so that's one differentiating point. So these questions will be asked. How will you differentiate an upper GI bleed from a lower GI bleed? So one is rumbling, noisy abdomen,
Not abdomen.
blood urea will be elevated, and the patient will have pain in the flanks if it's a lower GI bleed. So all these points you should know.
Okay.
Okay, next slide.
Yeah.
Any role for LFT?
Hypoproteinemia with hypoalbuminemia is there. Ma'am. Other than that, LFT is normal.
Okay.
Hypoprotein. Yeah. Other than that, it is LFT is normal.
Can we go forward?
Next I would like to do. I'd like to do a upper GI endoscopy, sir. Next.
Okay. Was it done?
Initially a colonoscopy, sir, followed by an upper GI endoscopy, sir.
Okay.
Colonoscopy up to it was done up to ileum, and ileum was normal. A linear ulcer was seen in the sigmoid colon, and 2 hemoclips were applied, and another ulcer around 1.1 centimeter was seen in the rectum, and biopsy was taken and sent for the
Picture quality is not great, sir. This was the linear ulcer in the sigmoid colon, where 2 hemoclips were applied on this ulcer.
Okay.
Can you describe the ulcer a little more? Where was it exactly? Sigmoid.
Yes, sir. Sigmoid colon, sir.
How big was it?
Around 1 into 1 centimeter. There was no stigmata of recent hemorrhage. There was no visible bleeding. There was nothing like an other end clot.
So what you see here is one ulcer you can see here. The other ulcer is at the other extreme right end.
No, sir. This was just a one solitary ulcer, sir. The other one was in the rectum. I just put the ulcer of the. I just put a picture of the sigmoid ulcer.
Okay. This is a linear ulcer, probably about 2 millimeter, 1 millimeter into point, or 2 millimeter into 10 millimeter size.
yeah.
And where was the hemoclip applied?
Over this ulcer, sir.
How many clips?
2, sir.
What was your colonoscopic diagnosis and differentials? Diagnosis colonoscopically. This is your finding. What was your
Well, question is to you. What was in your mind when you saw this? What is the diagnosis of this colonic ulcer? Clinical? Is there a histopathology?
Is it a bookworm ulcer? Is it a needle ulcer? Is it a Duracoy's lesion? What is it? What have you written in your final comments? And what were your differentials? That you have to tell me. You apply clips, that's okay, but what is it?
I think Dr. Jayanti is asking a very pertinent question. I think you should commit on what is the cause of this ulcer, whether it is a Dulophy or whether it is post-traumatic. What is the cause of this ulcer?
Is it just an amoebic ulcer or is it a threadworm, bookworm ulcer? What is it? What is your diagnosis at the end? You cannot just give a label, no, 2 bleeding ulcers, clips applied, and send the patient off. That's what I mean. What was your final diagnosis at colonoscopy? Can you hear me?
Dr. Binoy, do you know what was the...
No, sir. Let me intervene. It was like when we did the colonoscopy, the colon was looking at the mucosa up to the ileum was normal, and we found only these 2 ulcers. This particular ulcer was not very deep. It was looking like an acute ulcer, and as you can see, there was some, blood staining both ends. Both ends.
Yes.
Yeah, and we were at that point of time, we were not very sure from where he was bleeding. So I just put 2 clips. I mean, I was pretty sure that this is probably not the culprit, but just put 2 clips because I didn't want to take any chance. And this was not looking like any dulophoy. This was not. I mean, the rest of the mucosa was normal. There was no colitis, and there was another ulcer in the rectum. So since 2 ulcers, we took biopsies from the rectum and thinking that it could be something like non-specific ulcers, maybe because of drug-induced vasculitis, Behçet's, all those things were considered at that time.
Okay. So
this is a source of this massive bleeding with a falling hemoglobin.
no, this is very unlikely to contribute to the low hemoglobin level. I think this may not be the cause of his hemoglobin drop to 7.7 or 8.5.
Yeah, I was almost sure that it was not the cause of bleeding. There was no active bleeding. There was no stigmata. But when we went up to the ileum was showing, there was bile. There was no blood in the ileum at that time. Probably the bleeding would have stopped. And when we came back, because there was no other reason.
Yeah. Okay. So what was the next investigation done?
And plan was to investigate him more. An upper GI endoscopy was done. Subsequently, that also didn't pick up any lesion.
Okay. So we will come back to the discussion again. So what will be your next plan?
Next, I would like to consider to do because of the hemodynamic instability, CT angiogram.
CT angiography.
Yeah, CT angiogram.
If you had an enteroscopy available
I
with
would,
you,
yeah.
Will you do an enteroscopy first before doing a CT, or you will get a CT first and then go for an enteroscopy?
Here the patient had a mild hypotension. After resuscitating, the patient recovers, I'd like to consider enteroscopy better. Otherwise, I would go for CT angio if the patient is still hemodynamically unstable.
Yeah, if there is an active bleeding, that is the time when you can go for a CT and CT angio, because you are likely to pick up the lesion.
Yeah.
And that can be one of the modalities of workup, starting with a good CT angio. So was it done here?
Sir, I'd just like to add, after this initial investigation, after the initial volume resuscitation, after the Paxil transfusions, the hemodynamic instability settled. He initially had a shock index of 1.1 because the heart rate was 110 and systolic blood pressure was only 100. But later the tachycardia settled, the BP normalized, and he had no further episodes of bleeding PR. So we didn't go for a CT angio for this patient at this point of time.
Okay.
Then
So,
I would like to go for enteroscopy. CAPS, if it is available, or a capsule endoscopy. Enteroscopy would have been better, will be a better option, sir, because it can be diagnostic and also therapeutic. Next slide.
So,
do we have an endoscopy?
no, sir. So there were 2 issues which came up now. So one was we had some financial difficulties, couldn't investigate him too much, and at the same time we had also considered Meckel's diverticulum because it was a recurrent painless hematochezia, and previously a CT was negative. So when we had discussed with the nuclear medicine department, they were telling us that if at all the Meckel scan had to be done, it had to be done tomorrow. Otherwise, they would not have the radio tracer material to go ahead with the scan. We'll have to wait for the material to come again. So we went ahead with a Meckel scan first, not the enteroscopy.
Okay, okay. Shanai sir, can we call the next discussant? Shanai sir? Okay, Manmohan, thank you very much. I will call Dr. Annabra now.
Yeah, thank you.
Shanai sir, can we call the next discussant?
Yeah,
Dr.
please.
Dr. Annabra.
Now
How
it
is
is,
Meckel scan done? What is the material used, Dr. Annabra?
Sir, it is a 99 m per technate scan, sir. Because of the Meckel scan, it's the property because that 99 m per technate is has an affinity for the gastric mucosa, sir. So wherever the gastric mucosa is there, if it is also in the near the terminal ileum, that Meckel scan can pick up the ectopic gastric mucosa, sir.
Cells, vital cells, which has acid producing cells. Acid
Producing.
Right, yeah. It's not a gastric mucosa. It is gastric mucosa, but acid producing.
Yes, sir.
acid producing, yes.
Well, can you have false negative? Will Meckel diverticulum always have gastric mucosa or acid producing mucosa?
Sir, only 25 to 50% of the Meckel scan can have a gastric mucosa, sir, because the two most common, the other most common is a pancreatic mucosa, sir. So that can give a false negative result even if, but if the bleeding was there, sir, so definitely there are chances of gastric mucosa being present at the.
Okay, fine. Soren, please show us the picture. Okay, Dr. Annabra, interpret, please.
Sir, there is an uptake, sir, in the just near the terminal ileums and the lower small intestine.
What are all the darker spots, Dr. Soren? Can you concentrate on the various dark areas and let Dr.
Yes, sir.
Soren?
These are the static images. So I just show you the flow image. This was the flow image. So the one on the top left-hand corner is at 0, and lower down it's at 45 minutes. So some amount of uptake where you see will be the physiological tracer uptake, which is seen in the cardiac chambers, which can be seen in the lungs, which can be seen in the kidneys. But the maximum uptake happens in the gastric mucosa sometime around 10 minutes or 15 minutes, which is seen somewhere around the third row. And at the
pointer, please. With your pointer.
So it is the third panel which is important. The third row.
Yes, sir. So
okay, you start seeing the accumulation of the isotope in the ectopic mucosa.
Yes, sir. That it happens at the same time when you have accumulation in the gastric mucosa. Those two happen simultaneously.
Yeah, you can see both of them here. Yes.
So that is represented by the flow images.
So starting from third to sixth.
Can you just go back to the previous one, the enlarged version? Previous one.
Yes, sir.
Static image. The first two images which you have shown. Just one PPT above, just one. Okay.
Just for the information of all others, just point to the stomach, point to the Meckels, point to the urinary bladder, all those areas. Can you use the pointer?
Yes, sir.
Yes, shows the stomach, shows the kidney, shows the Meckels, shows the urinary bladder. Your pointer is not working?
Yes, sir. I am having issues with that.
All right then. Hope everyone knows that the top one is the stomach. On either side maybe kidney, you can see this. Then the small dot is Meckels and the lower one is urinary bladder.
Usually we find it in the right lower quadrant, sir. This one was in the umbilicus.
Centrally located, yes.
Yes, sir.
No, that can happen, but typically it is in the right lower quadrant.
Yes,
but
sir.
I think it is a little towards the midway.
Please move forward. Then what you do? Now, are you convinced, Dr. Annapura, that it is metals?
Sir, because there is a definite uptake, sir, it more likely, sir, confirms the diagnosis of Meckel, sir.
Okay.
So for further evaluation, surgical gastroenterology opinion was taken, and he was taken up for lab resection of Meckel's diverticulum. Next slide.
What is very peculiar about this Meckel's diverticulum compared to, say, sacculation of Crohn's disease?
Ma'am, the presence of ectopic gastric mucosa, what makes the complication more likely, ma'am?
Diverticulum or a false diverticulum?
Ma'am, it's a true diverticulum, ma'am, because it contains all the layer of the bowel wall, ma'am.
Where will it be? Anti-mesenteric border or the mesenteric?
Ma'am, it is from the anti-mesenteric border, ma'am. And they can be a sometimes, ma'am, connection towards the umbilicus also, ma'am. The bend formation can also be because of the remnant of the vitellointestinal duct.
What is the rule of two?
Ma'am, the rule of two says, ma'am, that it is found in 2% of population, ma'am. The male-female ratio is 2:1. The complication rate is 2% with the it is situated around 2 feet around the IC wall, most toward the proximal part, and it can.
Colonoscopy, the ileoscopy should be still deep, you know. Try to enter, especially when you have a patient with a bleed like this, painless bleed. When you think of some of these conditions, I think you could have just continued with the endoscopy and gone a little further down. You may have picked up the diverticulum in the first instance. That's the learning message of this patient.
Okay.
Yeah,
Yes.
I think in the first admission itself, if the person was continuously observed or had a technician scan, probably it would have been picked up. I think this is a lesson because sometimes we miss it in the first admission. Probably sometimes 2 or 3 admissions, you will pick it up. So the rule of 2 is 2% of the population. It is 2 inches long, 2 feet from the ileocecal valve. 2/3 have ectopic mucosa, and 2 types of ectopic mucosa, gastric and pancreatic, and 2% become symptomatic. This is the rule of 2. So the rule of
Yes,
2
sir.
has
Yes,
got
sir.
population, the length, the size of the Meckel's, how much is the ectopic tissue, then 2% become symptomatic. I think this is what Dr. Jayanti asked, the rule of 2. Okay, what happened
Yes.
after the?
Anything more? Any more slides? Histopathology?
Yes, sir. So this one was found around 2 feet from the IC valve, and it was resected with the ileal margins. This was the resected specimen. The histopathology showed the areas of the diverticulum. It showed mucosa along with gastric mucosa. There was foveolar epithelium and oxyntic mucosa, and it was compatible with a heterotropic gastric heterotropia.
Okay. Can we? I have asked Soren to give us a brief description about Meckel's for recapitulation. Is it ready with you?
1 minute, that means 1 minute, just one.
Yeah.
Supposing you did not have 99 and technician per technique, what will you do with this patient?
Ma'am, CT enterography can also sometimes pick up the Meckel's diverticulum. We can try with CT enterography once.
What are the other things? Tell us all the investigations you will do for the mid-gut. What are the
For mid-gut bleed, ma'am, the side viewing endoscopy, ma'am, to rule out Haemosuccus pancreaticus or.
This is not Haemosuccus pancreaticus.
Okay, ma'am. For Meckel's diverticulum, ma'am, CT enterography.
Other mid-gut bleed. Okay.
These methods of evaluating the small gut.
Other scopies, you know.
Enteroscopy, ma'am, we can try, ma'am. Enteroscopy can be of with ma'am wire capsule or ma'am device assisted enteroscopy, either single balloon or a double balloon enteroscopy.
Yeah.
Or now.
Those are the things that you should answer, not go for
Okay.
Spiral enteroscopy.
Spiral enteroscopy.
And what is the latest one on spiral?
Spiral. Okay.
Power spiral. Power spiral is the latest. Power spiral.
Authorized power spiral.
Okay. So wireless or wireless capsule endoscopy or a double blind endoscopy, spiral endoscopy, power spiral endoscopy. These are the ones which are available. Okay. And some question may come about the angiography, the role of angiography, interventional radiography, and control of bleeding for to site as well as to control bleeding. Sometimes we use interventional radiology techniques as well. Okay. Can Soren show us some of the slides? Until he loads up the slides, Shanai sir, please tell us the learning points in this case.
The learning point is that again and again we make the same mistake. I think this is not the first time that the bleed will be admitted and then discharged and then he come back. I think two important things we learn from this. When a person comes with an bleed, I think in addition to Meckel's, you should always think of diverticulum, because I had seen a cecal diverticuli and bleeding can be missed, not once, many a time, because the diverticulum will be in such a place that you will not be able to locate it. It will be behind a fold. And I think at least I had made one or two mistakes in my career. So I think two important things. One is Meckel's and second is diverticular disease, especially cecal diverticulum, which is bleeding. This is a learning point. Try to investigate them, and probably the best will be an isotope scan. And then if now that we have the power spiral, it can also make a diagnosis, and then you can have a very quick management strategy. Dr. Binoy?
Are you ready?
Yes, sir.
Is it in the okay? Then please fast. Please be okay.
So,
Start, please.
so the Meckel's diverticulum, it's named after the German anatomist and pathologist Johann Friedrich Meckel. It is the most common congenital abnormality of the small intestine. It is the most common cause of GI hemorrhage in children younger than 5 years. What exactly is the Meckel's diverticulum? It's a vestigial remnant of the omphalomesenteric duct, also known as the white line duct or the yolk stalk. So so usually between the 5th and 7th week of gestation, this omphalomesenteric duct, it undergoes separation from the intestine and the yolk sac. It just undergoes involution and it disappears. If it persists beyond 10 weeks, that's when you get omphalomesenteric duct abnormalities. The most common omphalomesenteric duct abnormality is Meckel's diverticulum. It is found in 67% of the all the abnormalities. Now, that is when it is only a single-sided blind duct and it could be attached to the umbilicus with a vitelline ligament. The others is when you have a vitelline cyst. So the central portion of the duct is dilated, the other two ends are blinded. You can also have a umbilical vitelline fistula, or you can have an omphalomesenteric band wherein the umbilicus is connected to the ileum, and that could be a cause of the obstruction. As all of us knows, and as already just been pointed out, there is a rule of two, which is there for the historical purpose. It is there in 2% of the population found within 2 feet of the IC valve. It's usually 2 inches long. Complications are in 2% of the cases. It has predominantly two types of ectopic tissue, gastric and pancreatic within the diverticulum. The clinical presentation is mostly at age 2 with intestinal obstruction, and the male to female ratio is 2:1. So there was one study which has been carried out by Division of Colorectal Surgery, Mayo Clinic. So this was a study which they did a follow-up over 50 years for 1,400 patients to see which people with Meckel's diverticulum will become symptomatic. So you can have an incidentally found Meckel's diverticulum, you can have an asymptomatic Meckel's diverticulum, or you can have a symptomatic Meckel's diverticulum. So for symptomatic Meckel's diverticulum, they found 4 risk factors: age less than 50 years, male sex, the diverticular length is more than 2 centimeters, and you have histologically abnormal tissue. The most important factor is histologically abnormal tissue. And if only one of these criteria are met, the risk is around 17%. If all 4, the risk of a symptomatic diverticulum is almost 70%. So the type of ectopic mucosa which you can find in Meckel's diverticulum, other than gastric or pancreatic, it can also be biliary, colonic, or duodenal. Now, this only 50% will have this, and of which the gastric mucosa will account to around 80 to 85% of all the Meckel's diverticulum associated ectopic tissue. So in totality, only 25% will have gastric mucosa. So the various presentations other than bleeding, which is the most common presentation, is abdominal pain, diverticulitis, an obstruction, or an intersusception. Now, with respect to the incidence of prevalence and the percentage of prevalence, the most common presentation is a rectal bleed or melena, which is around 35%. A diverticulitis occurs in 20%, and 1/3 of Meckel's diverticulitis undergoes perforation. It's an incidental finding in around 19%. You can get intestinal obstruction in 14%, and an interception can happen in 12%. Now, what is the exact presenting symptom in each age group is difficult to define. It is seen that children present more often than adults with bleeding, and adults get present with symptoms of obstruction. When exactly to suspect Meckel's diverticulum? In children with painless lower GI bleeding, in children with recurrent intersusception, in patients with features of acute appendicitis, particularly when the appendix has been removed, and unexplained painless lower GI bleeding in adults more than 40 years of age.
Okay.
So, presentations for bleeding, the most common presentation is a painless bleeding per rectum. The blood in the stool is usually maroon, even in patients with a massive bleeding, or when they present with hypovolemic shock. Now, what is usually seen with the left colonic bleed, which is bright red blood per rectum, is never seen in Meckel's diverticulum. And it is seen that adults usually present with a melena because there's a slower colonic transit time. Children will present with dark red or maroon stools. And the bleed could be chronic, could be insidious, it could be acute and massive. There is not much of literature supporting the type of bleed and its percentages. And usually, bleeding from Meckel's diverticulum does not require transfusions. And the reason why it bleeds is not because of the ulceration of the mucosa within the diverticulum. It is because of the ulceration of the mucosa and bleeding adjacent or just downstream to the diverticulum. And even though there is massive bleeding, mortality is usually uncommon because it occurs in the younger age group. They can compensate better, and hypovolemia will lead to lengthening vasoconstriction, and the bleeding usually diminishes or ceases. It can be self-limiting. So, other than that, obstruction can happen in Meckel's. There are multiple mechanisms of obstruction. One is intersusception. Intersusception is when the diverticulum itself is the lead point, or it could be the herniation or volvulus around the persistent fibrous vestigial duct. Now, it is a very common presentation in children when they present with recurrent small bowel intersusception. In adults, the tumor within the diverticulum can act as a lead point for intersusception. And abdominal wall hernia, that's another mechanism for obstruction in Meckel's. The herniation of Meckel's diverticulum is called a Litter's hernia. It can also present it with GI bleeding if it's incarcerated. The anatomical sites could be an inguinal, femoral, or umbilical. Diverticulitis again can cause narrowing of the intestinal lumen, and that can lead to partial or complete bowel obstruction. The inversion of the diverticulum also can be seen, and that can serve as a point of obstruction. All these are causes of obstruction in Meckel's. Diverticulitis is the third other manifestation. It usually is seen in patients who have been diagnosed with acute appendicitis, and the diagnosis is made only on table during an explorative laparotomy. Perforation is seen in 1/3. And you also have a chronic form of Meckel's diverticulitis called Meckel's ileitis. It can mimic Crohn's disease of the ileum. And rarely it has been reported as a predisposing factor to a small intestinal malignancy. So the diagnosis is the Meckel scan, which is the gold standard scan. You have a normal Meckel scan. You can also have an enhanced Meckel scan. An enhanced Meckel scan is when you prime the patient with H2 receptor antagonist or glucagon. So sometimes the other ways wherein you can pick up the Meckel scan is also used. One more use is for picking up Barrett's esophagus with dysplasia, because only those will have these mucin secreting cells. Now, a false negative or a false positive Meckel scan can be seen in intestinal duplication cysts, in intersusception, and in bowel obstruction also. SPECT has also been seen for diagnosing Meckel's, and high resolution CT angiography has also been used. So usually it is not picked up on a routine CT. It can be mistaken for a normal small bowel loop. And on routine images, it can even just present as an enterolith, which is completely indistinguishable from an appendiculolith.
Okay, thank you very much for that update. Comments, final comments by Shanai sir and other faculty members.
I think we had a good case and a good presentation by all the students, and I think a lot of input has come from Dr. Jayanti and my colleague Dr. Binoy Sebastian and Dr. Varghese Thomas. I think we had a wonderful case. Dr. Jayanti and Dr. Binoy.
I think a very good case for painless overt bleed. So I think students must know all the definitions: overt, occult, obscure, all these definitions. And I think the most important was what should have been done is expanded on the past history. And then it's easy, just 2 episodes of significant bleed, which is painless. So your differentials get shortlisted straight away. That would be my approach to this patient. And as Sir said, mention of the cutaneous markers, don't just say oral cavity. You're not looking at the oral cavity for candidiasis. No, you're looking for something very specific. Cutaneous markers of polyposis, cutaneous markers of internal malignancy, cutaneous other things. So basically, you're looking for markers of GI disorders. And I think the second message I thought was, since the first colonoscopy was normal and there was a high index of clinical suspicion of Meckel's, probably I would have continued to do an enteroscopy and move the scope further down, at least up to 2 feet, to confirm the diagnosis. Because at least to that extent, we can make a diagnosis of Meckel's. Duolephoid is just a spurting vessel that may get missed. But once we have a DD of a jejunal diverticulum bleeding, or it is an arterial splutter, then I think at least in the second occasion, the learning point which I learned was that you could have proceeded with an ileoscopy and gone a little further in, because that would have given us a clue as to what is the diagnosis. Well discussed, and thanks to you, sir, for excellent.
Thank you.
Yes.
Dr. Binoy.
Yeah, thank you, my dear teachers, for giving us this opportunity to present our case. Well, in fact, we had to, compromise and cut certain corners in managing this case, particularly investigating this case, primarily because of the financial reasons. After, the first episode where an upper and lower endoscopy was done and the CT was taken, this time when he came, they were not very keen to go with a lot of investigations, but I convinced them at least an upper and a lower scope is a must. And then we had a gut feeling that probably it could be a Meckel's, and that is one of the reasons. And I spoke to the relatives regarding gave them the options of going with an endoscope, but they agreed to proceed with the Meckel's scan. If it becomes negative, then the plan was to go ahead with the small evaluation, mucosal evaluation with the scope. And regarding the question by Professor Jayanti, we actually went deep into the ileum, probably around 15 to 20, 25 centimeters into the ileum. There was no evidence of any blood at that time. Probably the bleeding would have stopped and we couldn't see the diverticular opening. We thought about Meckel's diverticulum at that time, but we couldn't find any diverticulum. As far as we could go, we went inside, but we couldn't find anything.
Okay, sir. Thank you all. And I request Dr. These are the pictures of the Creutzfeldt syndrome, the hereditary hemorrhagic telangiectasia, Sothers spots, and blue rubber syndrome. And this is the skin lesion in Ehlers-Danlos, pseudoxanthoma elastica. Okay. Over to Dr. Srividya for the final vote of thanks. Are you there? Okay.
Yes, sir. Yes, sir. I would extend my sincere gratitude to Dr. Shenoy sir and Binoy Sebastian sir for this excellent discussion. And also, I would like to extend my thanks for Varghese sir and Jayanti madam for conducting this excellent discussion. And also, I would thank the discussants and the case presenter and discussants for conducting this such a good case and discussion. And also, I would extend my thanks for Sun Sickness for supporting our sessions. Thank you all once again.
Thank
So,
you.
sir, thank you all. Oh, good night, sir. Good night to all of you. Special thanks to Dr. Benoit Sebastian and the team for providing us the case and the discussion. Case for
Thank
the
you very
discussion.
much.
Now he's not seeing, he has to show himself. I remember him taking me around to Trivandrum long time back.
Yes.
I'm not.
Where are you? Come up at least on the virtual is something that we're believing in, no? Okay. Good night, sir.
Thank you, Jayanti.
Thank you.
Thank you, sir. And thank you, ma'am.
Thank you.
Good night to all.